Thank you very much for the opportunity to present here today. We'll talk today about multimodality MRI-PET imaging for improved detection of clinically significant prostate cancer. We all heard today how multiparametric prostate MRI is good, but it's far from perfect. Multiparametric, if you look at Cochrane review for detection of clinically significant prostate cancer, the sensitivity is rather good. It's 0.91. However, the specificity is rather low. It's only 37%. And this depends on obviously where you put the cutoff. If you take the cutoff at PIRAD 3, so any lesion that is PIRAD 3 or above is considered abnormal, these are the numbers. The numbers would change if you put the cutoff at PIRADS 4. If you put the PIRADS at PIRADS 4, then the sensitivity would go down and the specificity would be higher. So what are the main issues with prostate MRI? First of all, the false negative. We all know that around 10% of clinically significant prostate cancer is not MRI visible. The other issue is the PIRAD 3 lesions. Again, here we know that if you biopsy a PIRAD 3 lesion, about 50% would be cancer, but only 20% would be clinically significant prostate cancer. And the third very important issue, the inter-observer variability. It takes a lot of time to be good in interpreting prostate MRI. And if you have a good imaging guide, then you're golden. But if not, then you get questionable results and that are not reproducible. What do we know about PET PSMA? PET PSMA uses a radioactive tracer that is attached to prostate-specific membrane antigen. This protein is expressed in around 90% of prostate cancer. Moreover, and even more importantly, it is overly expressed in high-risk cancer, and the expression in lower-risk prostate cancer is much lower. Therefore, PET PSMAs are routinely used in staging of prostate cancer for both local T-stage, but also for end-stage and metastasis. And it's also used for recurrence in after local treatment. Can it be used to detect prostate cancer? Can it be used to help us inform how to perform a fusion biopsy? So we all know CT is limited in prostate anatomy as compared to MRI. And therefore, for detection, to actually direct a fusion biopsy using a CT PET PSMA is rather limited. But can we use a hybrid and get the good qualities from the PSMA and the good qualities from the MRI and combine them together to improve diagnosis of clinically significant prostate cancer? And even if we do prove that PET MRI can be better than your conventional MRI to detect clinically significant prostate cancer, how do we fit it in the clinical pathway? PET MRI machines are expensive, and the actual use of PSMA is also expensive. So it's not only expensive to buy these machines, but also expensive to use it. And how do we fit this into our everyday practice? So here I'll start showing you results from our lab. These results were published in Radiology in late 2021. And we used a pre-biopsy cohort of 100 patients that are normally found in every clinic. And what we did is we took all these patients and we performed a PET MRI before biopsy. And what we found is that a normal MRI and a normal PSA, normal MRI considered if there was a PIRAD 2 or 1 or no PIRAD 3 lesion, and normal PSA if the SUV, max SUV was lower than 2.5, was found in 37 patients. Abnormal MRI and normal PSA in 15 patients, vice versa, normal MRI and abnormal PSA in 9, and agreement between MRI and PSA in 38 patients. If you look at the numbers, the sensitivity of MRI versus a PET MRI was rather similar, around 90%. However, the specificity was much more improved for the PET MRI, so 76% compared to only 49%, and this was statistically significant. But do we need it every time? Do we need the PET MRI every time? So if you see this PIRAD-5 lesion, very dominant T2 lesion, and on the ADC map, you see the lesion as well, you don't really need the PET PSMA to tell you that you need to biopsy these patients. But where can we find it to be clinically useful? So we looked at two scenarios. First of all, the PIRAD-3 lesions. Do we need to biopsy these patients? Can we use PET MRI? Help us decide which PIRAD-3 lesion to biopsy. And another important is focal treatment. Can we use PET MRI to plan for focal treatment, plan the boundaries, and even more importantly, to surveil? So how do we follow these patients? Can we use PET MRI to improve our surveillance of focal therapy? So when we dive a little deeper into the study I showed you before, we saw that the most important contributing factor was among the PIRAD-3 lesions. Altogether, we had 23 patients that had a PIRAD-3 lesion. Of these, 13 had no PSMA uptake, and only 8% of these had clinically significant prostate cancer. If we look at PIRAD-3 with PSMA uptake, 40% had clinically significant prostate cancer detected. Therefore, using PET MRI to inform whether we need a biopsy on a PIRAD-3 lesion may be important. And here's a perfect example. There's a small TZ lesion here. That's a PIRAD-3. However, do we need to biopsy this? When we do a PET MRI, you see the PSMA uptake here. And therefore, we decided to biopsy, and we got actually a Gleason 8 prostate cancer. This is data around surveillance after focal therapy. There's not a lot of data out there, but this is a small trial, 29 patients presented in the Nuclear Medical annual meeting just this year. And you see that for follow-up of patients after focal therapy, there's improved specificity, sensitivity of PET MRI versus MRI alone. But here's a word of caution. When we looked at our own data, we have around 50 patients after focal therapy that had a PET MRI done and afterwards a biopsy. There are a lot of false positive with PSMA uptake after focal therapy. Mainly two reasons. One, PSMA is excreted in the urine, and whoever does focal therapy recognizes this cystic lesion that looks like a cyst on MRI. This cystic lesion is not actually a cyst. When you biopsy, it's actual gel material. This material sometimes has PSMA uptake, and it is always normal on biopsy. Another reason is the seminal vesicle. PSMA is excreted in the urine, and sometimes it has reflux of urine after focal therapy to the seminal vesicle. And when there's no clinical suspicion, PSA is normal, the MRI looks good, and there's PSMA uptake in the seminal vesicle, when you biopsy these are false positive. So we might find benefit, but still remains to be shown. What can be the future of PSMA hybrid imaging? We are now looking in my lab at conjugating PSMA to contrast-enhanced ultrasound and actually helping us direct biopsies during real time. The PSMA will be used as a targeting agent, and the ultrasound will help us inform in real time the fusion biopsies. We are now hopefully going to start phase 1 study of this, and hopefully we'll have something to report by next year. So in summary, PET MRI can be used to improve clinical significant prostate cancer diagnosis, but the actual fit into our clinical pathway remains to be determined. I'll be happy to answer any questions. Thank you very much.